This presentation will cover the normal newborn. The first 60 seconds after birth are referred to as the golden minute. It's the time when the baby must make crucial transitions from intrauterine life to extrauterine life. The baby has to establish respirations during this minute or begin to be ventilated with a mask. It's been statistically shown that the care the baby gets in its first 60 seconds will determine if it survives or not. There have been a couple of organizations who have banded together to share resources and knowledge and provide healthcare worker education in terms of neonatal resuscitation. There's a initiative called Helping Babies Breathe, and in conjunction with the International Liaison Committee for Resuscitation and the World Health Organization, a comprehensive approach to teaching healthcare providers neonatal resuscitation techniques has been created. And the group has been successful partly because they don't try to apply a uniform approach everywhere. So they understand that the resources and training and availability of personnel will be different in some countries, let's say Somalia, versus other countries. Sweden or the United States. They're going to be different. And so providers have to know how to use what they can have available for resuscitative purposes. The groups have been very successful. A recent report showed that the initiative has helped to bring down neonatal mortality by 47% worldwide, and the fresh stillbirth rate down by 24%. So that's quite a success. They've only been in action for a couple of decades. Oh, if you don't know what a fresh stillbirth refers to, that is a child who was fine in utero and then during labor or delivery died. So one of the most significant transitions that has to be made is the lungs and a respiratory pattern. And multiple things go into getting the lungs ready for this transition. During fetal life, the alveoli will produce lung fluid that itself will help in lung development. Surfactant, especially towards term of pregnancy, surfactant begins to be produced and will line the alveoli, and that surfactant reduces surface tension so that the alveoli can stay open and have a greater gas exchange surface. Then the fetal lung starts moving into the interstitial spaces, and it happens again before birth, during, and after birth. This lung fluid is absorbed by the lymphatic and the vascular systems so that there's not as much in the lungs after the baby's born as during in utero. So a number of factors combine to stimulate the respiratory centers in the brain and to cause an initiation of respirations at birth. One mechanism is a chemical mechanism. The chemoreceptors in the aorta and the carotid arteries respond to hypoxia of labor with decreased oxygen levels and increased PCO2 levels, and that helps to stimulate the respiratory center in the medulla. Mechanically, just the squeezing during labor helps to force out the lung fluid, and the resulting chest recoil after the birth helps to then draw in air to the lungs. Thermally, the skin will sense a temperature change after birth, and that cold external environment compared to the warmth in utero helps to stimulate breathing. And then tactily, the sensory stimuli, the baby that receives from nurses vigorously drying it, from tapping on the baby's soles of their feet, things like that, that will help to stimulate initiation of respiration. This is just a diagram kind of discussing those changes that I mentioned, both internally and externally, that help to initiate respirations. Now, we know that it takes a little bit of time for these adaptations to be implemented after birth. It may, in fact, take a normal term newborn up to 10 minutes to achieve O2 sat levels greater than 90%. Research has shown that the uh, fetus survives about a 30% decrease in oxygenation during labor. But after birth, the preductal SpO2 levels will increase. And like I said, it does take around, up to 8 to 10 minutes to exceed that 90% SAT level. And I will talk about preductal SATs in a couple of slides ahead. Cardiovascularly, the baby needs to transition from a fetal circulation pattern to a infant or neonatal circulation pattern. There will be increases in blood oxygen level, there will be shifts in pressure in the heart and lungs, a closing of the umbilical vessels, and a closing of the ductus arteriosus, foramen ovale, and the ductus venosus at birth. So during fetal life, there are three shunts. There's the ductus venosus, the foramen ovale, and the ductus arteriosus. And these carry most of the blood away from the lungs because it's not needed in those lungs. The lungs are underdeveloped, they're small, and they're not taking in environmental oxygen. It's all coming through the umbilical cord. So those little small collapsed fluid-filled lungs, they only accommodate a small amount of blood flow in their narrowed pulmonary vessels. And so there has to be a way, and it's these shunts of diverting blood from the lungs to the rest of the baby's body where it is needed for growth. The ductus venosus has oxygenated blood from the placenta that enters the fetal circulation through the umbilical vein. About a third of the blood is directed away from the liver into the ductus venosus, and that connects to the inferior vena cava. The rest of the umbilical vein blood flow goes through the liver before going to the inferior vena cava. This change happens closer to term pregnancy because the liver is going to need more perfusion at that point. And so then about 70 to 80% of the oxygenated blood goes to the liver. Now, the foramen ovale is a flap in the septum between the right and the left atria of the fetal heart. About 50 to 60% of the blood from the right atrium moves through the foramen ovale into the left atrium. The blood flows from the left atrium to the left ventricle and exits through the ascending aorta. This more oxygenated blood goes primarily to the heart, brain, head, and the upper body. Blood that does not go through the foramen ovale moves to the right ventricle, but the amount of the blood flow is restricted because of those narrowed pulmonary artery and blood vessels. This is a diagram of pre- and post-ductal SpO2 levels. So on the vertical axis, you have percent of SpO2, and then on the horizontal axis, you have time in minutes after birth. And then you can see plotted how long it takes the newborn to achieve SpO2 levels 90% or better. Okay, you can see that somewhere in there, the preductal takes anywhere from, it's after 6 minutes. It's more like 7 to 10 minutes to reach where we want it to be. So what are pre and post ductal SATs? This is a funny little diagram, but it basically is going to help me to kind of describe what it is that you'll be seeing done to the infants before they get discharged from home. So pre and post ductal SATs are usually measured by respiratory therapy, and they're usually done just prior to discharge or at least 24 hours after the baby's birth. What it's trying to do, this procedure, is catch those babies who have a heart defect that doesn't result in them being cyanotic or having an abnormal, physical exam. So the baby's born, it gets, the nurse examines it, the pediatrician examines it, and the baby looks okay, but maybe there's a hidden heart defect. And so the pre and post ductal SAT measurements are meant to catch those that are heart defect, but as I said, you're not seeing cyanosis or some other symptoms yet. So the right hand and the head are fed oxygenated blood after it leaves the heart. And if the postductal saturation is significantly different than the preductal, it indicates that there's right to left shunting at the foramen ovale and the ductus arteriosus that should have stopped upon birth. So what we're looking for obviously is a difference in the saturation level of that blood that has just entered the aorta and is feeding or oxygenating the brain and the right hand versus the oxygen level down in the baby's feet, which hopefully is pretty close to the oxygen level that we measured in the right hand. If there are greater than 10% or greater difference between those two measurements, it indicates that there might still be a patent ductus arteriosus or some other cardiac defect, that the baby had a problem or that they were not able to make that shift to extrauterine life by closing of the foramen ovale as they should have. Okay, so that's essentially what's being measured. So again, physical adaptations that have to happen in those first minutes of life, or once the umbilical cord is cut, the placenta is a low resistant kind of a circuit, and so the baby's source of oxygen is, gone, and so that will help to result in an increased systemic blood pressure, which of course is also necessary for helping to fuel gas exchange. The World Health Organization currently recommends cord clamping between 1 and 3 minutes after birth to improve a baby's iron status. It is not recommended that clamping happen earlier than 1 minute after birth. The American College of Nurse Midwives recommends 2 to 5 minutes after birth or until the umbilical cord stops pulsating. There are some providers who will kind of milk the cord towards the neonate several times before clamping. And again, the goal is to improve the baby's red blood cells and thus its iron status. This is a link to a nurse who provides a, I think, nice description of fetal circulation. Moving on to thermoregulation, there are a few characteristics of the newborn that can lead to its losing heat potentially. Their skin has very little subcutaneous or white fat. Their blood vessels lie closer to the surface, and overall their skin is their body surface area is significantly larger than compared to an adult's. And there are 4 primary ways the neonate can lose heat. This is through evaporation, conduction, convection, or radiation. In the upper left-hand corner, there is a brief discussion on evaporative heat loss. So this is the kind of loss that occurs by not drying the infant well so that it's damp, okay, giving the baby a bath and it doesn't stay warm enough and not dried enough afterwards, so evaporative water loss. Then in the upper right-hand corner, there's a brief discussion of conductive loss, and that's um, why we put the baby skin to skin, why we use warming objects, when we're going to put the object against the baby's skin. And so conduction is when the infant comes in contact with some colder surface, and then that cold is transferred to the baby. So convection is the loss of the baby's heat due to surroundings, and again, why we use a warmer or a draft-free room. And then number four is the transfer of heat um, to cooler objects, um, the radiant heat loss. And so again, we try to keep the baby away from drafts, from cold windows, put the baby in a warmer, and so forth. Thermogenesis is needed because the baby can't shiver to increase its own body temperature, and so there has to be mechanisms for it to help create its own heat. And some of those mechanisms are increasing its activity by being restless or crying, being flexed, drawing in of the limbs towards the torso. That helps to keep it warmer. A rise in the metabolism can help with this. And this usually is, again, as a result of the crying and the restlessness, increased activity. But then there's vasoconstriction as a way to decrease heat loss. And with vasoconstriction, we can actually see the baby in its first couple of days of life have its blue hands or feet, which is called acrocynosis. And then there's non-shivering thermogenesis, which is it's actually a primary method of heat production where the baby's brown fat is used for metabolism and then create heat. So brown fat is very important, and it actually generates more heat than does the white subcutaneous fat. So all of these factors help to increase the baby's temperature, but it will also with correspondingly increase its oxygen use, its glucose consumption, and that may tax the baby beyond the reserves that it has to cause hypoglycemia or respiratory distress or jaundice even. This is a diagram of the sites of the very important brown fat in the back, the axilla, between the scapula, along the abdominal aorta, and around the kidneys, adrenals, and sternum. There are multiple hazards of cold stress. Uh, it increases the oxygen need. It's going to increase the metabolic rate, and then the increased metabolic rate, of course, increases the oxygen need. It leads to decreased surfactant production. That in itself can lead to respiratory distress. Hypoglycemia can occur because of that increased metabolism and the fact the baby doesn't have perhaps much glycogen stored in its liver at the time of birth. There can be metabolic acidosis. This is usually as a result of the release of the fatty acids, that brown fat that has been used for metabolism. As it's burned, it has a negative pH, and so it causes acidosis. And then also a hazard is jaundice. So those increased circulating fatty acids does a couple of things. It prevents bilirubin from binding with albumin for conjugation purposes, and it also decreases the transport of bilirubin to the liver. So it has a few effects. This is a diagram showing that no matter the cause of the cold stress, whether it's evaporation, conduction, convection, or radiation, these things alone or together, any combination, can lead to a decreased body temperature and the cold stress. And so there are multiple outcomes, again, as mentioned, of the cold stress. There can be increased metabolic rate to try and help it stay warmer, but then you see the result of that is increased glucose use, increased oxygen use. And with the increased use of glucose, again, there could be risk of hypoglycemia. With the increased use of oxygen, that leads to potentially a decreased production of surfactant, hypoxemia. Those things can lead to respiratory distress. In terms of metabolism of brown fat, that, as mentioned, releases pH negative fatty acids. That's going to lead to metabolic acidosis, but also it displaces that bilirubin from the albumin binding sites that it needs to be conjugated, and that can lead to jaundice. In terms of vasoconstriction, with the peripheral vessels constricted, that'll lead to pale, cold, or mottled skin. And I mentioned acrocyanosis is the bluish, cold hands or feet. And then constriction of the pulmonary vessels will lead to circulation problems that could cause the infant to revert back to um, its fetal circulation pattern, which will then, as the diagram indicates, lead you to respiratory distress because the baby is not in utero anymore and has to adapt to the atmospheric oxygen. Hematologically, the erythrocytes have a shorter lifespan in the neonate than for the adult. Um, the hemoglobin and hematocrit and erythrocytes are all going to be at higher levels in the newborn than for the adults. And that kind of makes sense when you think about how in utero the baby had to grow and develop and live life with less oxygen available than it's going to have after birth. Okay? Um, in terms of leukocytes, the baby is born with an elevated white count that is normal, but it normally decreases back down to expected levels within 4 to 5 days, something like that. There are clotting irregularities. Um, the baby is born with a very low level of vitamin K, which is, as you know, needed to activate clotting factors. And so this is why newborns are given aquamaphytin or a vitamin K shot that's necessary to help them to activate their clotting factors. So question, newborn is placed under a radiant heat warmer. The nurse knows that thermoregulation presents a problem for newborns because is it that the renal function is not fully developed and heat is lost in the urine? Is it that their small body surface area favors more rapid heat loss than does an adult's body surface area? They have relatively thin layer of sub-Q fat that provides poor insulation? Or their normal flexed posture favors heat loss through perspiration? The answer is C. That's the only one that is accurate. Okay, when looking at the GI system of the infant, we think of the stomach, the intestine, the digestive enzymes, and the stool. So the intestines have more surface area for absorption, in proportion their size for the baby in comparison to an adult's. But they're more prone to dehydration if the baby gets diarrhea. Okay? So those two things sort of balance each other out a bit. Stools normally progress from thick greenish-black meconium to a loose greenish-brown stool, and then later to a lighter, kind of a milky stool. The stools of breastfed babies are frequent. They look like mustard seeds, a yellowy pasty thing. It takes first few days for the normal intestinal flora to be established. Until then, the neonatal gut is considered sterile, and it does not have the digestive enzymes that it needs. Fortunately, both amylase and lipase are present in breast milk, and that's yet another one of the important reasons for initiating breastfeeding. This is just a little diagram of the size of the newborn stomach and how much it changes from day 1 to 1 month. And I think it's a nice visual as we have moms who worry that they're not feeding their newborn enough milk because their milk hasn't come in. We can reassure them that the size of their stomach is so tiny anyway that the amount mom is making is quite likely to be just the right amount for the baby to tolerate at that point. At this age, the cardiac sphincter between the stomach and the esophagus is floppy, and so there tends to be a frequent spit up or regurgitation. This is just a little diagram again of what stools tend to look like. Um, as mentioned, with breastfed babies, it's kind of a pasty mustard looking stool with a sour smell, and it usually happens after each feeding. Um, Babies that are breastfed tend to poop more often. 4 times a day is not unusual compared to formula fed babies. And the formula fed babies usually have kind of a pale yellow brown with a foul smell, kind of a feces smell to them compared to the breast milk fed baby. In terms of the hepatic system, um, very important liver functions include maintaining blood glucose levels and of bilirubin, production of factors necessary for blood coagulation, the storage of iron, and the metabolism of drugs. So specifically, remember that the liver um, holds glucose in the form of glycogen so that it can be used as energy later. And so that's a really important mechanism for maintaining normal blood glucose levels. The bilirubin conjugation we'll look at in a future slide. The production of factors for blood coagulation is important. Um, Prothrombin and multiple coagulation factors are produced in the liver, and so these aren't jump started until we give the baby its vitamin K injection. The liver also is responsible for storing of iron. The liver and the spleen both do this. Um, Iron supplements are usually prescribed by the pediatrician somewhere between the 4th and the 6th month for breastfed babies. We expect that the baby's own liver can carry it for a while, but then by 4 to 6 months, supplementation is necessary. If the mom is formula feeding, most of those formulas already have iron supplementation in them. And then the liver, remember, is responsible for metabolism of drugs, but it does a very poor job of this for the newborn. And so this is yet one more reason why any meds that the mom is prescribed or is taking needs to be evaluated and checked for its potential to be transferred through breast milk to the infant and then have some bad effect on the infant. Okay. So during the last trimester, the fetus starts to have glucose stored in its liver because, as I mentioned, it will need energy after birth. And this energy is needed for a number of things. The baby has to have energy to survive the stress of delivery. It needs energy to support its new respiratory efforts, heat production, moving against gravity for the first time in its life. That takes energy, and all those other functions that the baby has to do on its own for the first time since it's exited mom's womb. And so a stable blood glucose is needed for all of that. Infants that are at risk for hypoglycemia are those that are preterm and late preterm, small for gestational age, large for gestational age, those born to diabetic mothers, exposed to stressors, or who have undergone cold stress. So